from Cardiac Pathophysiology, right? So, in question number one, we have atherosclerotic lesions of the coronary arteries can limit blood flow to the myocardial regions supplied by the affected vessels. In some patients, certain medications can cause a redistribution of blood flow away from the ischemic areas, exacerbating existing myocardial ischemia. Which of the following drug effects is most likely to produce this phenomena? Option A, coronary arteriolar dilation. Option B, decreased myocardial contractility. Option C, epicardial vessel dilation. Option D, negative chronotropic effect. And option E, systemic venous dilation. So pause it and give the answer. So the correct answer for this question is option A. Why? Let us see to the explanation. Hemodynamically significant atherosclerotic lesions, that is greater than 70% occlusion, reduce the amount of blood supplied by a coronary vessel to the corresponding myocardial territory. In response, the myocardium releases long-acting endogenous substances, for example, adenosine nitric oxide, that cause dilation of the coronary arterioles, right? Leading to a downstream reduction in vascular resistance, okay, and recruitment of additional blood flow to the region. Arterioles that supply areas of significant ischemic myocardium can become maximally dilated at rest, okay, maximally dilated at rest, limiting their capacity to further increase the blood flow. Now, pharmacologic stress agents, which are used most commonly, like adenosine and with that dipyridamole, right, are used during myocardial perfusion imaging to stimulate exercise-induced coronary arterial dilation, right, and assist in identifying areas of ischemic myocardium that either ischemia is present or not. Okay, most of the time, administration of these drugs will result in significant increase in blood flow to non-ischemic myocardium, right? So that will worsen the condition, and no change in blood flow to ischemic myocardium, right? Because additional blood flow is recruited proximally. Now, if we want to try to differentiate between these two conditions, at rest and on the other side, if we use adenosine or dipyridamole, which will provide condition like exercise. So, what would happen normally if there is stenosis on one side, right? And like over here, the blood flow will be the same as to the non-ischemic side, right? So this is normal myocardium, right? And these are dilated maximally. So in case of ischemic myocardium, arterioles maximally dilated to maintain blood flow. Okay. Now, if we use adenosine, they cannot dilate more, right? So what will happen with adenosine to the non-ischemic area? The blood flow will be increased, right? But on the other hand, uh, here in this case on the stenotic side, there will be no increase uh, in blood flow, so arterioles cannot dilate further, so flow unchanged, right? In some patients with extensive coronary artery disease, the recruitment of additional upstream blood flow is limited due to proximal atherosclerotic disease, right? A reduced coronary flow reserve. Okay, in such ascitic, these drugs can cause an absolute decrease in blood flow to the ischemic myocardium, right? As most of the limited blood supply is redirected toward the newly vasodilated areas of non-ischemic area, just like above. This redistribution of blood flow leading to worsening ischemia is referred to as coronary steal, right? Like coronary steal syndrome, right? Just like the same is above, but over here the proximal stenosis is look at it. Okay, so this is the rest condition. Over here again, the blood flow is these vessels are dilated maximally. Now with adenosine, what will happen if there is proximal stenosis, that will limit uh, available blood flow, right? So on this side, which is non-ischemic, there will be increased blood flow, but on this side where there is stenosis, the arterioles cannot dilate further, so the flow would be stolen from here, so less blood flow to this side, and over here to non-ischemic area the blood flow will be increased, right? Why not option B, D, E? Decreased myocardial contractility, negative chronotrophy, and systemic venous dilation, leading to reduced preload. All decrease myocardial oxygen demand, right? Through a reduction in cardiac work. These mechanisms act to improve myocardial ischemia globally and will not result in redistribution of blood flow away from the areas of ischemic myocardium, right? Why not option C? The epicardial vessels are large coronary arteries of the heart. For example, right coronary artery and left circumflex coronary artery. Although dilation of these large arteries play a role in increasing myocardial blood flow, coronary blood flow regulation is mostly mediated by arterioles, right, which are small and narrow blood vessels. Dilation of large coronary arteries would improve cardiac blood flow and wouldn't trigger coronary streal syndrome, right? So, increases in resting blood flow to ischemic myocardium are primarily mediated by locally acting substances like adenosine with that nitric oxide, right? They trigger coronary artery vasodilation. Pharmacologic arteriolar vasodilators, for example, adenosine with dipyridamole, mimic the vasodilation that occurs with exercise, may cause redistribution of blood flow from ischemic to non-ischemic areas of myocardium. For example, that would lead to coronary streal syndrome. So in question number 2, we have a 53-year-old man comes to the office with progressive exertion dyspnea. He has smoked 2 packs of cigarettes per day for the last 35 years. Physical examination shows increased anterior-posterior diameter of his chest. Auscultation reveals decreased breath sounds and scatter wheezes throughout his lungs. Examination of his extremities is unremarkable. Echocardiography reveals moderate dilation of the right ventricle and increased central venous pressure. The absence of pericardial edema in this patient is best explained by which of the following compensatory mechanisms? Option A, decreased capillary permeability. Option B, decreased circulatory aldosterone levels. Option C, decreased interstitial fluid pressure. Option D, increased plasma oncotic pressure. Option E, increased tissue lymphatic drainage. Pause it and give the answer. So the correct answer for this question is option E. Why? Let us see to the explanation. Now, if we look at the factors affecting interstitial fluid volume, right? If we go on the arteriolar side at the capillary levels, right? On the other side, we have renewal side, right? So what would happen over here is, let's say if these are the arterioles, right? The blood will be pushed from arterioles outside by hydrostatic pressure, right? On the venular side, right? The interstitial if let's say if we say the plasma or the you know the pressure, the uh, the proteins inside the vessels, right, over here will attract the fluid which is inside the interstitium, so that is called oncotic pressure, right? Also with that we have interstitial fluid pressure that will move the fluid from the interstitium into the vessels, right? And with that if we go down we have lymphatic duct system, right? That will also carry the uh, fluid from inside the interstitium into the vessels, right? So this patient has dyspnea without signs of lung hyperinflation and a heavy smoking history, right? Suggesting COPD, chronic obstructive pulmonary disease, right? Chronic hypoxia in COPD can lead to pulmonary vasoconstriction, and that would lead to increased pulmonary arterial pressure, and that would lead to right heart failure. That is cor pulmonale, right? Which is confirmed by this patient's echocardiogram. In turn, right heart failure leads to increased central venous pressure, right? Because the fluid will not move from the ventricles. Let's say fluid over here will not move in, will accumulate it over here, right? Okay. So with that elevated peripheral capillary hydrostatic pressure, encouraging the development of peripheral edema, right? If we have noted in case of uh, left heart failure, we will have the pulmonary edema, and if there is like because the fluid is moving in the backward, and if we have left side heart failure, this will accumulate in the peripheral portion of the body, right? So that would cause peripheral edema. So the fluid movement across the capillary wall, that is filtration into the interstitium, is dependent on hydrostatic pressure, oncotic pressure, and capillary permeability. It is tightly balanced by lymphatic drainage, right? That will push the blood against these forces, right? Which returns interstitial fluid to the vasculature, to the vessels, right? Peripheral edema, that is accumulation of excess fluid in the interstitial space, develops when transcapillary plasma filtration exceeds the resorptive capacity of the lymphatics. Factors that favor development of edema include elevated capillary hydrostatic pressure, so that would move the fluid from the vessels outside into the interstitium. So high capillary pressures increase plasma filtration into the interstitium, particularly in dependent tissues, right? In causes include sodium and water retention, right? Sodium and water retention, for example, in heart failure and in renal failure, uh, and with that arteriolar dilation, for example, dihydropyridine calcium channel blockers, right? And impaired venous return, uh, for example, venous thrombosis. Okay, uh, the other cause could be decreased plasma oncotic pressure, right? Plasma proteins like albumin, for example, generate oncotic pressure that pulls interstitial fluid back into the capillary bed venules, right? Edema develops in condition with decreased albumin levels, for example, nephrotic syndrome, liver cirrhosis, right? If there is damage to the liver, or if there is malnutrition, right? Okay, and the other thing is lymphatic obstruction, because this is the most important thing regarding this, because decreased lymphatic return impairs removal of excess interstitial fluid, right? So common causes of lymphatic obstruction include filariasis, right? Invasive malignancies, and iatrogenic etiologies. They have also given this MCQs on invasive malignancies. We will talk about that. For example, in iatrogenic etiologies, we have surgical lymph node dissection, right, and radiation therapy. Okay, the peripheral lymphatics can significantly increase lymphatic drainage from baseline, allowing compensation for increased capillary fluid filtration that can temporarily delay the development of peripheral edema, right? But this is temporarily delay, right? However, because the peripheral lymphatics offload fluid to the central venous system via the thoracic duct, which in heart failure is already volume overloaded, right? The overall ability to compensate is limited. So, in long term, in chronic situation, it would not uh, be useful. Okay. Why not option A and D? Although increased plasma oncotic pressure and decreased capillary permeability oppose edema formation. These are opposing, right? Neither is associated with COPD. They are not associated with chronic obstructive pulmonary disease. Severe COPD may cause polycythemia due to hypoxemia, right? So RBC will be formed, right? But erythrocyte concentration doesn't affect plasma oncotic pressure, right? Why not option B? In patients with heart failure, activation of RAS, renin, angiotensin, aldosterone system leads to increased aldosterone level, right? That causes sodium and water retention. So that would exacerbate uh, edema formation, right? Volume expansion causes increased atrial, that is ANP and BNP, brain natriuretic peptide. The ANP would be released from atria and BNP would be released from uh, not from brain, right? It would be released from ventricles, right? Which can partially counteract the effects of RAS activation. However, aldosterone levels remain elevated. Why not option C? Because decreased interstitial fluid pressure favors flow into the interstitium and would contribute to the development of peripheral edema. But is in this case they are not asking about factors that would contribute to the development of peripheral edema. Is they are asking that which are the factors which would decrease the formation of peripheral edema, right? So peripheral edema results from the accumulation of fluid in the interstitial space. Factors that promote edema include elevated capillary hydrostatic pressure, decreased plasma and cardiac pressure, and impaired lymphatic drainage. In chronic heart failure, increased lymphatic drainage initially offset factors favoring edema. So initially, right? This is important. Temporarily delaying edema development, but not in chronic case, right? In question number 3, we have a 67-year-old man comes to the emergency department due to progressive shortness of breath and chest tightness. He has had no lightheadedness or syncope. The patient takes lisinopril for hypertension and metformin for type 2 diabetes mellitus. He has smoked a pack of cigarettes daily for the last 40 years. The BP cuff is inflated to 140 mm of mercury and the pressure is released very slowly. Okay, at 120 mm of mercury, intermittent Korokov sounds are heard only during expiration, right? At 100 mm of mercury, Korokov sounds are heard throughout the respiratory cycle, right? So the drop in the pressure is from 120 to 100, right? So it is the drop of 20 mm of mercury during inspiration, right? This physical examination finding can be seen in which of the following condition? Option A, aortic valve disease. Option B, mitral valve disease. Option C, myocardial ischemia. Option D, pericardial disease. Option E, peripheral vascular disease. So pause it and give the answer. So the correct answer for this question is option D, right? Why option D? Because this is the case of pulsus paradoxus, right? What would happen in case of pulsus paradoxus? During inspiration, the drop in pressure is greater than 10 mm of Hg, right? Just like is in this case, right? The pressure drop is more than 10, right? So if we plot a graph, this is the graph for respiration, right? And this is the systolic BP over here. So during inspiration, the normal drop should be less than 10, right? But over here we can see this is greater than 10, right? From 120 to 100 mm of mercury. So this would be considered as pulsus paradoxus, right? This phase over here is representing inspiration, right? Because the fluid is increased inside our lungs, right? And over here this phase is representing expiration. The air fluid has been decreased, right? So systemic arterial pressure normally falls by less than 10 mm of mercury during normal inspiration. This is important, right? Pulsus paradoxus refers to an exaggerated drop that is greater than 10 mm of mercury uh, in systolic BP during inspiration. It is detected by inflating a blood pressure cuff above systolic BP, like in this case up to 140 mm of mercury, and gradually deflating it, so the BP will go on down, right? So the difference between the systolic pressure at which Korokov sounds first becomes audible during expiration, like in this case at 120, and the pressure at which they are heard throughout all phases of respiration quantifies pulsus paradoxus, that is 20 mm of mercury in this patient, right? Inspiration causes increase in systemic venous return, resulting in increased right atrial pressure. Under normal conditions, this results in expansion of right ventricle, right, into the pericardial space with little impact on the left side of the heart. However, in conditions that impair expansion into the pericardial space, like is in this case, for example, in acute cardiac tamponade, right, the increased right ventricular volume occurring with inspiration leads to bowing of interventricular septum towards the left ventricle. So let's say if we draw this, they will push. Let's say this is normal. Like in this case, in acute cardiac tamponade, they will push this right atrium to or ventricle to that side, so this will decrease this area, right? So this leads to a decrease in left ventricular end-diastolic volume and stroke volume, right? With a resultant decrease in systolic pressure during inspiration, right? Why not option A, fixed left ventricular outflow tract obstruction, for example, valvular aortic stenosis? That can cause pulsus purvis et tardus. This is important, right? Which is palpable, slow rising, low amplitude pulse due to diminished stroke volume. If there is diminished stroke volume, that is called pulsus purvis, and there will be prolonged left ventricular ejection time. That is called as pulsus tardus, right? And this is in case of aortic stenosis, right? One option B, patients with chronic severe mitral regurgitation have a bounding pulse with a brisk upstroke due to increased left ventricular ejection volumes, right? Arterial pulses are overall reduced in amplitude in patients with mitral stenosis due to reduced stroke volume. So in both cases, the stroke volume would be reduced, right? Why not option C, myocardial ischemia or infarction? They can lead to decreased systolic PP, right, or hypotension due to reduced cardiac output, right? But it wouldn't expect to cause pulsus paradoxus, right? They are not causing pulsus paradoxus. Why not option E, peripheral vascular disease causes decreased pulse amplitude within the affected extremities? This is important, right? This is most commonly observed in lower extremities, peripheral vascular disease, right? In lower extreme, which will have diminished or absent distal pulses caused by widespread peripheral arterial disease. So the pulsus paradoxus uh, is defined by decrease in systolic BP greater than 10 mm of mercury during inspiration, right? With inspiration, most commonly seen in patients with cardiac tamponade. This is important, but can also be seen in severe asthma, COPD, and constructive pericarditis. Question number 4, continuing with question number 3. So the patient is tachypneic and unable to speak in full sentences. Examination reveals prolonged expiration and prominent bilateral wheezing, right, pointing to one special disease. Heart sounds are normal. Chest imaging shows a normal sized heart, okay, and hyperinflated lungs with flared diaphragm. This is pointing to a disease that is called COPD, in which we have the patient would have flared diaphragm and hyperinflated lungs. So with that, bedside echocardiogram reveals no intrapericardial fluid accumulation or pericardial thickening. So they are eliminating the case of tamponade, right, or pericardial effusion. Which of the following physiologic changes is most likely to provide immediate relief in this patient? Option A, cyclic MP accumulation in smooth muscle cells. Option B, cell membrane stabilizing of mast cells. Option C, inhibition of eosinophil degranulation. Option D, entrapted histamine receptor firing in epithelial cells. Option E, opening of calcium channels in smooth muscle cells. So pause it and give the answer, right? So the correct answer for this question is option A. Why? Because for COPD, what do you think? What we use, right? These are beta 1 agonists, right? Let us see to the explanation. So this patient presentation with dyspnea, tachypnea, prolonged expiration, bilateral wheezing, suggestive of acute exacerbation of COPD, asthma, or COPD, obstructive pulmonary disease, asthma, or COPD. Okay, acute obstructive pulmonary exacerbations are primarily treated with beta adrenergic agonists, which produce relaxation of bronchial smooth muscle by stimulating the beta 2 adrenergic receptor. This receptor is a G-stimulatory protein coupled receptor that activates adenylyl cyclase that would increase intracellular cyclic AMP concentration. Asthma and COPD exacerbations are most frequent causes of pulsus paradoxus in the absence of significant pericardial diseases, for example, pericardial effusion or constructive pericarditis. Right? There is a small normal variation in intrathoracic pressure with respiration, which drops 2 to 5 mm of mercury below the atmospheric pressure during inspiration. In patients with severe asthma or COPD exacerbation, this drop in intrathoracic pressure becomes greatly exaggerated and is transmitted to extrathoracic structures. Just like in case of cardiac tamponade, the pressure drop was greater than 10 mm of mercury in during respiration, right? But over here, okay, uh, the the extra thoracic the, the pressure over here in the from the intrathoracic pressure would be increased, right? Okay, this leads to excessive drop in bp with inspiration, right? Just like in that case, that is detected is pulsus paradoxus. So same is cardiac tamponade. Why not option b? Cromolyn sodium inhibits mast cell degranulation and release of histamine, uh, and with that leukotrienes, so inhibiting those things, right? Used occasionally for management of chronic asthma, but not effective for immediate relief of acute asthma or COPD exacerbations. Why not option C? Eosinophil degranulation would be impaired by corticosteroids, right? Which play an important role in the treatment of acute asthma or COPD exacerbations. However, beta agonists provide immediate relief, right? It will take no time. Whereas corticosteroids would take several hours. This is important to a few days to take effect. Okay, this is important, right? They can confuse between these two questions, between these two answers, like beta 2 agonist and corticosteroids. So the mechanism by which it would increase the cyclic AMP is the uh, beta agonist, not corticosteroids, right? So why not option D with that? Histamine is one of the several mediators released in response to hypersensitivity reaction that can lead to bronchial smooth muscle contraction. However, antihistamine therapy not effective in treatment of asthma or COPD exacerbation, right? Okay, why not option E? Calcium channel agonists not used in acute treatment of asthma or COPD exacerbation. Why? On the contrary, increased calcium influx potentially worsen bronchial smooth muscle contraction. So it shouldn't be used, right? Because they are contraindicated. So, asthma and COPD exacerbation are the most frequent causes of pulsus paradoxus. In the absence of significant pericardial disease, beta adrenergic agonists control acute asthma and COPD exacerbations, right? By causing bronchial smooth muscle relaxation, not contraction, right? This is important via increased intracellular cyclic AMP. So, in question number 4, in question 5 and 6, they have repeated the same 4 and 5, third and fourth question, right? So we are moving to question number 7. We have a 66-year-old man is brought to the hospital due to sudden onset chest pain and nausea. Medical history includes diabetes mellitus, BP is 70 by 60 mm of mercury, pulse is 60 per minute, right? Okay. Lungs are clear on auscultation, okay. So, and with that, jugular veins are distended, so pointing toward right side of the heart failure, right? Because if there is lung auscultation is clear, that means there is no left heart failure, right? ECG shows ST segment elevation and 2-3 AVF, that is representing inferior wall problem, right? Chest X-ray is unremarkable, so an inferior wall MI is diagnosed, right? Emergency cardiac catheterization reveals complete occlusion of the proximal right coronary artery. As we know, the 2-3 AVF, which is providing inferior surface of the heart, is supplied by this coronary artery, right? Okay, so the patient is uh, persistently hypertensive in the cardiac catheterization lab. Which of the following hemodynamic findings are most likely to be observed in this patient? Cardiac output, pulmonary capillary wedge pressure. This is the pressure on the left side of the heart. Central venous pressure, that is pressure on the left on the right side of the heart, right? If we draw this, right, they are asking about this. So this word is this one is CVP and this one is pulmonary capillary wedge pressure, right? So in they're asking about this case. So in option A, decrease, 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 all are decrease. In option B, decrease, decrease, increase. Option C, decrease, increase, decrease. Option D, increase, decrease, decrease. Option E, increase, increase, increase. So pause it and give the answer. So the correct answer for this question is, um, let me show, let me draw this for you, let me clear this for you, right? So this is the case of right heart failure, right? So the fluid cannot move toward the from the lungs toward the left atrium, right? So the pressure in the left atrium would be decreased, right? So the pulmonary capillary wedge pressure would be decreased, right? One thing is decreased. Okay, with that is this is the case of heart failure. So the cardiac output will be also decreased, right? So the fluid will be, let's say if the there is right heart failure, so fluid will be accumulated on this side in right ventricle. This will be moved in the backward direction, right? So here the pressure would be increased, and as we know that central venous pressure is the pressure in the right area, and also with that will move in the backward direction, like superior vena cava, all those things, right? So this means that central venous pressure would be increased. So we are finding an option where central venous, so cardiac output over here is decreased, pulmonary capillary wedge pressure again over here has been decreased, right, as in this case, and also with that central venous pressure is increased, right? So this is the correct option for this question, right? Okay, let us further explain this question. So in case of right-sided heart failure, the primary disturbance is the right ventricular dysfunction, right? So that's why systemic vascular resistance that would be increased, due to which the cardiac output would be decreased, right? So if the cardiac output is decreased, right, the fluid accumulation would be there in the right ventricle, then back in the left, then back in the right atria, right? So that would increase right atrial pressure or central venous pressure, but the pressure in the left atria, right over here, that would be decreased. Why? Because the fluid cannot move into the left side of the heart. Okay, so in this patient is in acute MI affecting inferior wall, right, which is usually supplied by the right coronary artery. Inferior wall MI can involve only the left ventricle, both the left or right ventricles, or only the right ventricle, right? This patient's severe hypotension, prominent jugular venous distension, and clear lungs, right? Absence of pulmonary edema, because that would occur in left side of the heart, suggest primary right ventricular involvement, right? In acute right ventricular MI, contractile dysfunction causes pressure to bake up into the right atrium and vena cava, creating elevated central venous pressure, as we talked about this case. Right ventricle output drops, decreasing blood flow through the lungs to the left atrium, as I mentioned, and creating a low pulmonary capillary wedge pressure. With less blood reaching the left atrium, left ventricular filling decreases and systemic cardiac output drops, causing hypotension and reflex increase in SVR, systemic vascular resistance, in effort to maintain PP. Okay, these hemodynamic findings of right ventricular MI mimic those seen with obstructive shock, right? Involving blockage of blood flow through the pulmonary circulation, that for example in case of pulmonary embolism, and contrast with the classic cardiogenic shock resulting from left ventricular contractile dysfunction. In that case, the both the pressure, like pulmonary capillary wedge pressure, and with that the central venous pressure, both would be decreased in cardiogenic shock, right? This is important. In classic cardiogenic shock, blood backs up at the left ventricle, causing increased left atrial pressure, increased pulmonary capillary wedge pressure. Both things, as I mentioned, would be increased, and that would cause pulmonary edema. Right? Now, if we go through this quickly, obstructive shock, the primary disturbance is impaired cardiopulmonary blood flow. Right? For example, in case of pulmonary embolism and tension pneumothorax. So, the what would happen? There would be increased in systemic vascular resistance. Right? That would lead to decreased cardiac output. Right? If there is decreased cardiac output, and what happens if let's say if there is pulmonary embolism in the lungs, right? Embolus is in the lungs, so that will not leave the fluid or blood into the left side of the heart, right? So if there is no or less blood flow to the left atrium, pulmonary capillary wedge pressure would be decreased. But as we know, this fluid will be accumulated in the backside, in the right ventricle, then in the right area. So the central venous pressure would be increased, right? But on the other hand, if we look at the case of uh, cardiogenic shock, both the pressure would be increased, right? Because the fluid over here would be uh, uh, the fluid cannot be the blood or the fluid cannot be delivered to the body, right? Because the SVR, that is systemic vascular resistance, that would be increased. So the here would be the fluid accumulation in the left ventricle, then again the backward flow into the left area. So pulmonary capillary wedge pressure would be increased. Again, this fluid would go to the lungs, right? Would go to the lungs, and then again to the in the backward direction to the right ventricle, then to the right area. So again, in that case, the central venous pressure would be also increased, right? I talked about cardiogenic shock. Primary disturbance, left ventricular failure, decreased cardiac output, pulmonary capillary wedge pressure would be increased, central venous pressure would be increased. Is in reflex mechanism, SVR would be increased to maintain cardiac output, right? In hypovolemic shock, right, the primary disturbance is a decreased blood volume. So if there is less blood volume, so there will be less venous return. So over here the pressure would be decreased because there is no fluid accumulation, because there is no fluid over here, so central venous pressure would be decreased. Now if we move to the lungs, the fluid move to the lungs, and again to the right, let's say to the left area. Over here is the fluid is not coming from the right side to the left side, so the pulmonary capillary wedge pressure over there would also be decreased, so that would decrease cardiac output. And is a reflex mechanism, systemic vascular resistance would be increased, right? Now if we go to the septic or distributed shock, right? Septic is the example of is one of the example of distributed shock. Like in distributed shock we also have others like neurogenic shock, right? Here the primary disturbance is peripheral vasodilation. This is really important. In all other the shock examples we have increase in SVR, but over here the mechanism is starting from decrease in SVR. In all other shock we would have decrease in cardiac output, but this is opposite to those, right? um, Here the cardiac output would be increased, right? This is important. What would happen if there is increase in cardiac output? So the central venous pressure would be decreased, and with that the pulmonary capillary wedge pressure would be decreased, right? This is important. And one more thing which is important regarding this is over here the percent mixed oxygen saturation over here would be increased, because the blood flow over here would be increased, right? And that will take less time for oxygen exchange, right? So there will be more uh, mixed oxygen saturation, right? But in all other cases, that would be in all other shock, that would be decreases. I'm talking about the mixed oxygen venous saturation, right? This is important. These are few differences on which they will test you. In case of high output heart failure, the primary disturbance is again decreased in SVR, right? For example, in case of AV fistula, there will be decrease in SVR, so that would increase cardiac output, right? Since there is high output, right? So that would increase central venous pressure with that pulmonary capillary wedge pressure, right? So from these things, what you have to learn that the cardiac output is increased in case of septic shock, right? One thing which you have to remember. While in other, the cardiac output would be decreased, right? And with the exception of neurogenic shock, we would talk about that. And with that, the SVR in all cases, SVR would be increased, right? Uh, uh, with the exception of high output heart failure and septic shock. These things are important. These things are important. Cardiac output is increased in high output heart failure with that septic shock, right? And again with that, SVR would be increased in case of all other, with the exception of high output heart failure and the septic shock. These two things are important. And again with that, the percent saturation, mixed oxygen venous saturation, would be increased in case of septic shock, while in other all those cases that would be normal or decreased, right? So we were saying in hypovolemic shock, low blood volume causes low central venous pressure, which leads to low pulmonary capillary wedge pressure and cardiac output, right? In septic shock, peripheral vasodilation reduces SVR, compensatory increase in cardiac output, right? As I mentioned about this thing, central venous pressure and pulmonary capillary wedge pressure are low due to vascular leakage and low circulating blood volume, right? In high output heart failure, low SVR triggers an increase in the cardiac output in an effort to maintain BP. Despite high output, the heart cannot keep up with the resulting increase in venous return, elevated central pulmonary capillary wedge pressure, and central venous pressure. Right? Remember this thing. In septic shock, the pulmonary capillary wedge pressure and central venous pressure would go down, but over here in high output, high cardiac output, that would be increased. So inferior valve MI commonly involves the right ventricle, right? MI primarily involving the right ventricle is marked by elevated central venous pressure, low pulmonary capillary wedge pressure due to reduced blood flow through the lungs to the left atrium, and low cardiac output, right? This contrasts with classic cardiogenic shock, which results from left ventricular failure and leads to elevated pulmonary capillary wedge pressure with pulmonary edema, right? As I mentioned about this thing. In question number 6, we have a 34-year-old woman brought to the emergency department due to chest pain. The patient reports that she went to bed feeling well and woke up in the middle of the night with severe crushing chest pain that radiated to her left arm. She has had similar episodes over the past year that typically occur in the early morning and spontaneously resolve after several minutes. The patient has a history of occasional migraine that responds to acetaminophen. She doesn't use alcohol, tobacco, or illicit drugs. BP is 150 by 100 mm of mercury. Pulse is 110 per minute. Respirations are 14 per minute. On physical examination, the patient appears distressed and diaphoretic. Okay. ECG reveals ST elevation and lead 1 AVL, that is representing to uh, lateral wall MI, and V4, V5, V6 interior wall MI. So interior lateral. Okay. The patient is given nitroglycerin, which improves her symptoms. Percutaneous coronary angiography is performed and no obstructive lesions are observed. Which of the following most likely to be involved in the pathogenesis of this patient chest pain? Option A, decrease endothelial expression of endothelin 1. Option B, granulomatous inflammation of arterial media. Option C, hyperactivity of vascular smooth muscle. Okay. Option D, increased endothelial expression of prostacyclin. Option E, ulceration of thin atheromatous fibrous cape. Pause it and give the answer. So the correct answer for this question is option C. Why option C? Let us see to the explanation. So this patient most likely is a vasospastic angina that was formerly called Prince Marl angina, right? Which involves intermittent coronary artery vasospasm leading to myocardial ischemia. The condition likely results from hyperactivity of arterial smooth muscle due to combination of endothelial dysfunction and autonomic imbalance, right? What? Combination of endothelial dysfunction with that autonomic imbalance. So, the major underlying defect in vasospastic angina is likely deficiency of vasodilatory nitric oxide in the coronary artery endothelium, causing acetylcholine released from vagus nerve terminals to trigger vasoconstriction rather than vasodilation. If there is deficiency of nitric oxide, then there would be vasoconstriction, right? Caused by acetylcholine. Point to be noted. Patients typically experience episodes of a recurrent chest pain, right? That spontaneously resolve within 15 minutes. This is important. Would resolve spontaneously. The, the episodes often occur at rest or during sleep, right? When vagal tone is at peak, right? Because at that time the patient would be at rest, so there will be parasympathetic activation. Is with typical angina, there may be associated diaphoresis, nausea, dyspnea. But unlike typical angina, patients are usually young, so this is important. Age would be less than 50, right? And like most of the risk factors for atherosclerotic coronary artery disease, right? For example, hypertension and diabetes is they have not mentioned such things, right? However, smoking is a strong risk factor. Point to be noted. Strong risk factor, likely due to its contribution to endothelial dysfunction. Why? Because that would lead to endothelial dysfunction, right? Okay. Vasospastic angina is usually diagnosed by ambulatory ECG. This is important. Diagnosed by ambulatory ECG, that is Holter monitor, that shows ST elevation during an episode of chest discomfort followed by coronary angiography to rule out atherosclerotic coronary artery disease. Sublingual nitroglycerin is effective in relieving an active episode of vasospastic angina, and CCB, calcium channel blockers, for example, diltiazem and amlodipine, are effective in preventing episodes. Why not option A and D? Endothelin 1 is a potent vasoconstrictor, right? Not a vasodilator. It is a potent vasoconstrictor, and prostacyclin is a vasodilator, right? Therefore, if there is decreased expression of endothelin 1 or increased expression of prostacyclin, would stimulate coronary vasodilation rather than vasospasm, right? Like in this case, they have not mentioned increase, right? If it would increase, right, then it would be better. But now they have mentioned decrease, right? Like if there is endothelial expression, right, that would cause vasoconstriction. But here they have mentioned decreased, so it would lead to vasodilation. Important. Why not option B? Granulomatous inflammation of arterial media occurs in Takayasu arthritis, a large vessel vasculitis affecting the aorta and its major branches, right? Important. Young women of Asian descent, really important. They will mention this case, that a young woman of Asian descent, okay, most commonly affected and sometimes develop angina due to coronary artery involvement. However, limb claudication due to subclavian artery involvement accompanied by constitutional symptoms like fever and fatigue is more common presentation. So what is more common presentation? Let me highlight this: limb claudication with that constitutional symptoms, right? And they would have mentioned a young woman of Asian descent, right? Would say Takayasu arthritis. That would be the case of Takayasu arthritis. So granulomatous inflammation of arterial media, okay, which is a large vessel vasculitis. Point to be noted. Why not option E? Ulceration of the thin fibrous cape overlying an atherosclerotic plaque can lead to unstable angina, right? Characterized by intermittent chest discomfort, similar to the vasospastic angina. But what is the difference? Atherosclerotic coronary artery disease is unlikely in this young woman, right? without significant coronary artery disease risk factors, right? That is associated with CAD. So, vasospastic angina involves hyperactivity of coronary artery smooth muscle. Patients are usually less than 50, young, okay, without significant risk factors coronary artery disease. However, okay, they experience recurrent episodes of chest discomfort, typically during rest or sleep, and resolve within 15 minutes. Point to be noted. A 1 hour old neonate with prenatally diagnosed is tetralogy of Fallot is admitted to the neonatal intensive care unit with cyanosis. The mother is a 28-year-old gravida 3 para 2 who received routine prenatal care. The patient was born via spontaneous vaginal delivery at 35 weeks gestation. Initial Apgar scores are 5 and 7 at 1 and 5 minutes after birth, respectively. The neonate's lips, fingers, and toes appear cyanotic. Okay. This patient should be immediately treated with a medication producing which of the following effects? Option A, decreased left ventricular end-diastolic pressure. Option B, increased pulmonary surfactant levels. Option C, increased pulmonary vascular resistance. Option D, maintenance of ductus arteriosus patency. Option E, stimulation of fetal hemoglobin production. So pause it and give the answer. The correct answer for this question is PDA, right? Which will improve the cyanosis. Let us see to the explanation further. Tetralogy of Fallot is cyanotic congenital heart defect characterized by pulmonary stenosis, overriding aorta, right ventricular hypertrophy, and VSD. When pulmonary stenosis is severe, tetralogy of Fallot is ductal dependent lesion, okay, that relies on the patency of ductus arteriosus for adequate oxygenation. The ductus arteriosus is a fetal vascular structure, right, that connects the main pulmonary artery with aorta. In utero, blood which is oxygenated by the placenta bypasses the lungs by flowing from the pulmonary artery through the PDA directly into the aorta, right? But after birth, lungs fill with oxygen, so pulmonary vascular resistance uh, decreases, causing the direction of flow through the ductus arteriosus to reverse, that is from aorta to the pulmonary artery. Ductus arteriosus patency is maintained by circulating prostaglandins released by the placenta. They are talking about before birth, right? But after birth, prostaglandin production would stop, right? And the ductus arteriosus starts closing, right? And severe tetralogy of Fallot, critical pulmonary stenosis or atresia limits blood flow from the right side of the heart to the pulmonary circulation for oxygenation. Instead, blood reaches the pulmonary vascular bed via retrograde flow from the aorta through the ductus arteriosus, right? Without flow through the ductus arteriosus, affected neonates are unable to oxygenate blood, right? These patients are cyanotic immediately after birth, right? As in this neonate, and require immediate administration of prostaglandin E1 to maintain patency of the ductus arteriosus. So we can use for the treatment prostaglandin E1 or E2, right? So that will remain the patency, maintain the patency of ductus arteriosus. Why not option A? Because heart failure medications that reduce preload, for example, diuretics, decrease left ventricular end-diastolic pressure. This decrease would not improve right ventricular outflow tract obstruction, right, or increase retrograde flow through the ductus arteriosus in patient with tetralogy of Fallot. The administration of pulmonary surfactant can improve lung compliance in preterm neonates. But in this case, the baby is normal, roundabout because has been delivered in 35th weeks, so not with respiratory distress syndrome, right? Because the primary pathology in tetralogy of Fallot is cardiac rather than pulmonary, right? Surfactant will not improve oxygenation. Why not option C? Increase pulmonary vascular resistance would worsen the pathophysiology of tetralogy of Fallot by decreasing blood flow from aorta through the ductus arteriosus into the lungs, right? Why not option E? Hydroxyurea increases the fetal hemoglobin production, right? Thereby improving the oxygen carrying capacity of blood in sickle cell anemia. So that is used in the treatment of sickle cell anemia, right? In tetralogy of Fallot, oxygenation is impaired due to inadequate pulmonary blood flow from the right ventricular outflow tract obstruction, right? So, severe tetralogy of Fallot is a ductal dependent lesion that requires blood flow through the ductus arteriosus from the aorta to the pulmonary artery for adequate oxygenation. Prostaglandin E1 and 2, right, prevents closure of the ductus arteriosus, so should be immediately administered to all cyanotic neonates with suspected ductal dependent lesion. Let me explain this for you guys. Ductal dependent congenital heart defects. So we have pathophysiology, the function of the ductus arteriosus, right, and the type of defect that is associated with that. Right heart obstruction. If there is right heart obstruction, that would allows blood flow from the aorta to the pulmonary circulation. That is associated with tetralogy of Fallot with severe right ventricular outflow tract obstruction, tricuspid atresia, and pulmonary atresia. Now, if there is left heart obstruction, allows that would allow what would be the function of ductus arteriosus? That would allow blood flow from pulmonary artery to systemic circulation. For example, in case of hypoplastic left heart, with that critical aortic stenosis, critical aortic coarctation, and interrupted aortic arch. Now, if there is parallel circulation, we also had talked about this in the previous session. So, allows mixing of oxygen. What is the function of ductus arteriosus in that case? It would allow the mixing of oxygenated with the deoxygenated blood, right? For example, in case of transposition of great arteries, that means let's say this is if this is the heart, right? Normally what happens from the right side, right ventricle, there is the outflow tract of pulmonary artery, but in this case there will be aorta on the right side, right? And on the left side, normally as we know that there is aorta, but in this case there will be uh, pulmonary artery on the left side, right? Okay. Now we have a 72-year-old man comes to the clinic due to episodic lightheadedness. The episodes typically occur in the morning when the patient adjusts his shirt collar or tightens his tie and he briefly feels like he's going to pass out. The patient has thyroidectomy 5 years ago for a large benign tumor. He also has hypertension and takes amlodipine. Okay, BP is 135 by 78 mm of mercury. Pulse is 78 per minute. Physical examination reveals no heart murmurs or carotid broods. ECG shows normal sinus rhythm. This is important. The patient is given an ambulatory ECG monitoring device. During symptomatic episodes, the device is most likely show which of the following: atrial fibrillation, Obed's type 2, second degree heart block, paroxysmal supraventricular tachycardia, sinus pause, ventricular tachycardia. So pause it and give the answer. The correct answer for this question is sinus pause. Why? Let us see to the explanation. This patient with episodes of pre-syncope, that is presenting with lightheadedness, right, feeling of impending loss of consciousness that occur when he adjusts his shirt collar or neck tie, most likely his carotid sinus hypersensitivity, that is called CSH. Remember, this is also being asked in the next uh, pathophysiology questions. We would talk about that, right? uh, the condition results from poorly sensitive carotid baroreceptors that stimulate an excessive vasovagal response uh, to tactile stimulation. CSH, carotid sinus hypersensitivity, is most commonly seen in adult elderly men, right? Like in this case, a 72-year-old man. Okay, underlying carotid atherosclerotic disease and prior neck surgery, for example, is in this case thyroidectomy has been done. These are risk factors. Okay, the baroreceptor response in CSH mimics the normal response to increase BP, but is more exaggerated, right? Increased parasympathetic output leads to prolonged sinus pause, right? For example, 3 to 5 seconds, and a decreased sympathetic outflow causes marked peripheral vasodilation. The resulting delay in ventricular contraction and decreased systemic vascular resistance leads to profound reduction in BP and transient loss of cerebral perfusion, right? That manifests as pre-syncope or syncope. Okay, why not option A, C, and E? Because intermittent tachyarrhythmias, including AFib, with rapid ventricular response without paroxysmal supraventricular tachycardia, for example, AVNRT, atrioventricular nodal reentrant tachycardia, and ventricular tachycardia, can cause syncope due to loss of cardiac output and reduced cerebral perfusion. Of the three tachyarrhythmias, ventricular tachycardia is most concerning. However, CSH is more likely, that is, carotid sinus hypersensitivity, is more likely in this patient with symptoms associated with tactile stimulation of the carotid sinus, like in case of necktie, right? Okay, then why not option B, advanced atrioventricular block, for example, complete heart block with that uh, Mobet's type 2 second degree heart block can cause pre-syncope or syncope, but is also less likely than CSH in this patient with symptoms associated with tactile stimulation of the carotid sinus, right? Again, like neck time. Okay, so carotid sinus hypersensitivity, most commonly seen in elderly men, involves exaggerated vasovagal response to tactile stimulation of carotid sinus baroreceptors, adjusting a shirt color or necktie. This thing is important. They would have mentioned this case for you. The resulting increase in parasympathetic output leads to prolonged sinus pause, right? That would prolonged sinus pause that contributes to excessive drop in BP that would lead to transient loss of cerebral perfusion. There will be less blood flow to brain. Okay, that would manifest is pre-syncope or is lightheadedness or syncope, right? In the next question, in question number 9, we have a 62-year-old woman with no significant medical history is brought to the emergency department due to fatigue and substernal chest pain that began 6 hours ago. On arrival, ECG is consistent with ST segment elevation MI. Coronary angiography shows right dominant coronary circulation and a thrombotic occlusion of the proximal right coronary artery, which supplies blood to the patient's right ventricle and inferior and posterior portion of the left ventricle. A drug eluting stent is placed and she is discharged 2 days later without complication. After 6 weeks, the patient follows up in the clinic and undergoes echocardiography that shows left ventricular contractile dysfunction with normal right ventricular function. Which of the following characteristic of the right ventricle compared to the left ventricle best explains these echocardiography findings? Higher oxygen, higher resting oxygen extraction, less dependence on collateral circulation, less ischemic preconditioning, more active fibroblast proliferation, perfusion during both systole and diastole. So the correct answer for this question is perfusion during both systole and diastole. Let us see to the explanation. If we look at the characteristic of left and right ventricle, then right ventricle, muscle mass uh, is high in case of left ventricle, right, than that of right ventricle. If we look at resting oxygen extraction, that is high in case of left ventricle. Why? Because muscle mass is high, because and with that there will be more demand, right? And over here on the left side that would be low. Coronary perfusion, that is during diastole only, right? While in right ventricle, that is through the cardiac cycle, that means during systole and diastole. Collateral circulation more developed in case of right ventricle, that's why that is more good, right? While less developed on the left side. Okay, left ventricle. Ischemic preconditioning, right? Here it is low, while in that case on the right side that would be high. Okay, so myocardial infarction MI involving the left ventricle commonly leads to scarring and sustained reduction in contractile function. However, contractile function of the right ventricle almost always returns to normal following MI. Why? Because we would see these things that um, in case of right ventricle there is relatively small muscle mass and afterload of the right ventricle. Okay, with that there is large capacity to increase oxygen extraction, right? With that, the coronary perfusion throughout the cardiac cycle. Okay, so let us see some of the reasons for protection of the right ventricle from infarction include relatively small muscle mass, right, as I mentioned, and with that uh, less afterload, right, of the right ventricle create less oxygen demand, as I mentioned, and necessitate lower oxygen extraction at rest. This allows for large capacity to increase oxygen extraction during periods of ischemia. Okay, the relatively low systolic pressure of the right ventricle, less than or equal to 25 mm of mercury, allows for coronary perfusion throughout the cardiac cycle. During MI, this enables the right ventricle to pull blood from the collateral blood vessels, as we know are well developed in the case of right ventricle during both systole and diastole. In contrast, the high systolic pressure of the left ventricle, for example, that is 120 milligram mm of mercury, okay, blocks coronary blood flow of the left ventricle walls during systole, right, allowing fusion during diastole only. So these factors likely contribute to typical clinical course of MI involving the right ventricle, which is acute right ventricular contractile dysfunction, often leading to profound hypotension and hemodynamic instability. Acute mortality risk is high, but there is minimal long-term right ventricular dysfunction for those who survive. Why not option A? They're asking these characteristics regarding the right ventricle, right? Okay, so why not option A? Because the large muscle mass of the left ventricle necessitates higher oxygen extraction at rest, with relatively little capacity to increase oxygen extraction during periods of ischemia. Why not option B? The most robust collateral flow occurs from the left to right coronary arteries, suggesting the right ventricle has more developed collateral circulation and may be more dependent on collateral flow than the left ventricle. Why not option C? Ischemic preconditioning refers to myocardium being repeatedly exposed to mildly ischemic states, for example, during periods of exercise, which stimulates adjustments, for example, collateral circulation development, cellular improvements in oxygen utilization that allow future ischemic states to be better tolerated. The right ventricle is thought to experience heightened ischemic preconditioning compared to the left ventricle, contributing to the protection of the right ventricle from infarction. Why not option D? Fibroblast proliferation, more prominent in the muscular left ventricle, where repair of large muscle and large mass of tissue is needed. Right? So that is for left ventricle. So the right ventricle is relatively protected from myocardial infarction, and contractile function of the right ventricle usually returns to normal following MI. Factors contributing to this production include relatively small muscle mass with high capacity to increase oxygen extraction, perfusion throughout the cardiac cycle, and heightened ischemic preconditioning, right? So they can increase collateral circulation, right? And the last question for today's session, we have a 58-year-old man comes to the emergency room due to headache. Medical history is significant for long-standing hypertension and medication non-adherence. BP on arrival is 231 by 135 mm of mercury. 20 minutes after IV hydralazine is administered, BP is 145 by 95 mm of mercury. So this is a sudden drop in BP because of hydralazine, IV hydralazine. Okay, over the following 24 hours, serum creat increases from 1.1 to 1.6 milligram per deciliter. That means there is some type of injury in the kidney. Okay, urine sediment demonstrate abundant granular cysts, right? One of the important characteristics. Which of the following process best explain this patient acute kidney injury? Option A, alteration of the BP flow relationship in renal arterioles. Option B, drug induced glomerular injury due to aminocomplex formation. Drug induced renal interstitial inflammation. Drug induced renal tubular injury due to crestal deposition. Pre-renal isothemia due to global reduction in cardiac output. So pause it and give the answer. The correct answer for this question is option A. Why? Let us see to the explanation, right? This patient with chronic hypertension is hypertensive urgency. He received hydralazine, a fast-acting antihypertensive agent, after abrupt normalization of BP. He's developed acute tubular necrosis, right? Presented with granular cysts. This sequence of event is consistent with normotensive ischemia, right? That is inadequate renal perfusion despite a normal BP. The BP would be normal, but there would be inadequate renal perfusion that would lead to ischemia. Like if we see to the autoregulation of blood flow in chronic hypertension, let's say on this side we have renal blood flow and over here we have mean arterial pressure. In normal, in healthy patient, the curve would be just like that, right? The BP and the perfusion would be normal, right? Like over here we can see the blood flow over here is normal, and also the BP, the mean BP will also be normal. But in case of chronic hypertension, this curve would be shifted toward the right side. And if we decrease suddenly the BP, right? Suddenly if we decrease the BP, here over here the BP is suddenly decreased, but the perfusion, the blood flow to the kidneys is low. So there will be ischemia, there will be hypoperfusion. So the flow would be decreases and that would lead to ischemia and that would lead to acute tubular necrosis. Blood flow autoregulation allows organs to receive the same perfusion across a wide range of pressure, right? The pressure would be changed, but the perfusion would be the same. The blood flow would be the same. In the kidneys, blood flow autoregulation involves two key mechanisms: myogenic response, tubuloglomerular glomerular feedback. Okay. In case of myogenic response, efferent glomerular arterioles reflexively contract when they sense greater stretch forces, that is high BP, right? In case of tubuloglomerular feedback, high arterial pressure causes hyperfiltration, so that would increase glomerular filtration rate, so would increase sodium and chloride delivery to the macula densa, which secrete vasoactive mediators, adenosine, to construct the efferent arterioles. The autoregulation response protects organ from dangerous persistent BP elevations. In chronic hypertension, there is baseline construction of the afferent glomerular arterioles. This causes the entire renal autoregulation curve to be shifted to the right. A hypertensive patient's kidneys receive less blood flow at any given BP. This is important. At any given BP, that would receive less blood flow, right? Relative to those of a healthy patient without hypertension, right? Quickly lowering the BP to normal is in this case with IV hydralazine, right? Like up to 145 by 95 mm of mercury causes a steep drop in blood flow. The blood flow would be decreased more, right, leading to ischemic acute tubular necrosis. As a result, BP should be lowered gently, right, targeting above normal values. For example, 25% of reduction over several hours. That is a good procedure, right? So that wouldn't then lead to any injury. So why not option B, in which there is amino complex formation? Drug-induced lupus, a rare adverse effect of hydralazine, causes acute kidney injury due to amino complex mediated glomerulonephritis. However, in active urine sediment, like for example red cells, white cells, and casts, and other systemic signs of lupus, like rash, pleuritis, this is important, would be expected, right? So that would be presented with rash, pleuritis, uh, and with that active urine sediment, for example RBC, white cell, and casts. Okay. Why not option C? Drug induced allergy. Interstitial nephritis is an eosinophilic acute kidney injury, usually triggered by beta lactam antibiotics and NSAIDs. Right? It occurs after continual exposure, several days, and eosinophiluria is present. High level of eosinophil, right? And this is, allergic type of nephritis, important. So that's why eosinophil count will be high. Why not option D? Some drugs like acyclovir or acyclovir and entecavir can precipitate in the urine, causing acute kidney injury due to crystalluria. This is important. Urine sediment may show tubular necrosis, granular casts, but crystals are usually also seen, right? Why not option E? Decreased cardiac output can cause prerenal acute kidney injury, which may evolve to ischemic acute tubular necrosis. However, treatment with hydralazine lowers the systemic vascular resistance, which reduces cardiac afterload. This will lead to increase in overall cardiac output, right? But in this case, in this option, they are saying decreased cardiac output, right? So, in patients with long standing hypertension, chronic autoregulatory shift in the BP flow relationship occurs, affording less perfusion at any given pressure. Therefore, excessively rapid correction of BP toward normal may induce relative ischemia. Thank you.